with all the research projects that I did in the framework of my activities for the reference laboratory, I have worked in several actually international working groups focusing on standardization and harmonization around vitamin D. I'm still in an IFCC committee for standardization of thyroid hormone function tests. So all this background has, I have used all this background to prepare the slides of today. And I will use some of the things from this past experience in order to try to explain the things I would like you to understand. So, what do we do with current phosphatidylethanol measurements? We try to assess someone's drinking behavior by comparing the numerical result for a blood sample to a decision limit. And there's also a growing consensus to use a common or a global decision limit. On the other hand, we monitored changes in someone's drinking behavior by comparing new results versus previous results. And as the world becomes more and more guided by or smaller effects, and we are all very mobile and we sometimes hop from lab to lab, a patient file can start to have input from different laboratories for the same analyte. Those two ways of applying or handling a PET result is exactly the same what you do when you are diseased. You have too low vitamin D, you go to the GP, he will measure it once and he will say, it's below 30, you're depleted. Please supplement yourself. And then after a while, you go back, he will have a second measurement and he will compare. But maybe he has changed labs by then. So also there, he needs to make sure that the result is exactly comparable to his previous result. So we do exactly the same. That is what we try to do with these PET measurements. And I'm not saying that it's okay or it's not okay, maybe it's too soon to do these things, but we do it. So if we want to do it, we have to assure that some things are right, that things are comparable, that results from one point in time to another point in time are exactly comparable. And they should be comparable regardless the measurement principle that we use, regardless the method that has been used, regardless the actual measurement procedure, including the test kit and the test-specific calibration, and regardless the laboratory where the analysis is carried out. And if we are honest to ourselves, we know that at this point in time, we are not there yet. These are results from an EQA scheme. I actually forgot to put a reference, but these are results from the EQA scheme from Equalis. And you can see that there's a twofold difference in results for the samples, despite we claim to measure the same PET 16081. But clearly, one has a PET result of 1 micromole per liter in lab A, and I think over 2 in lab B, which is a huge difference. So we've also seen in the presentations yesterday, where we do method comparisons, that sometimes we find a difference of 30% between two laboratories. So to overcome these issues, we, or in the field of clinical chemistry, they have developed the concept of implementation of a uniform reference measurement system. And in practice, a uniform reference measurement system comes down to agreeing on just a few parameters. There are just a few things which we need to agree on, such as the definition of the analyte, and we will use a common basis for calibration. I will try to explain those two things to you in the next slides. And as I already said, there are many examples in the broader field of clinical chemistry And if you would, for example, look at the activities of the IFCC or the GCTLM, the Joint Committee on Traceability of Laboratory Medicine, which is a mouthful, you will see that this concept has been applied successfully for many parameters. One of the most successful ones is hemoglobin A1C. And so this concept has been around for over 30 years, and there are many well-defined protocols established. So I'm not just inventing something, it's based on the things that we do for years now in the field of clinical chemistry. So the implementation of a uniform reference measurement system is also sometimes referred to establishing meteorological traceability. And how to do so is laid down in an ISO document, the 17511-2020. I will not go through this document, and this document actually combines 5 different concepts or 5 different ways, depending on which key elements in this for traceability exist or don't exist. So I just restrict in the presentation to the one which I think is applicable for PET. A very important remark that I would like to make in the beginning of this presentation is that depending on the analyte, we use the term harmonization or standardization. I will try to explain the difference somewhere along the presentation, because I feel there it's more at its place. But standardization in this way does not mean agreeing on a common protocol for sample preparation and measurement. It absolutely doesn't mean that everybody from now on has to do exactly the same. No, on the contrary, the principle is really very clear. Everybody is free to use whatever method of choice, as long as the end result can be traced back, is meteorologically traceable to the SI units or the highest international standard available. So that is something which is important, and in other words, it means that each application laboratory can use whatever method available, provided it measures the correct analyte and it utilizes a methodology which is fit for purpose and well validated. But that is the responsibility of the laboratory. So some theory, I'm sorry, and I will try to make the link to a well-established analyte just for you to see the line and try to, or maybe have a better understanding. So the analyte that I have chosen was vitamin D. Vitamin D is a sunshine vitamin. We determine it in serum. It's measured via immunoassay and LCMS, and it actually, if you refer to vitamin D, you might refer to precursors and active or non-active metabolites. There exist multiple analogs, just as for PET. We have the 25-hydroxyvitamin D3 and D2. I've put it in green because that's our clinically relevant measurement. That's what we measure. When your GP measures your vitamin D, he will measure, or let measure, the 25-hydroxyvitamin D3 and D2. The 3-epi 25-hydroxyvitamin D3 and D2, which is actually just a hydroxyl group which is flipped over, that is not measured. It should not be measured. It's inactive, and we would like to avoid to measure it. And then you have other analytes on 25, also 24-25 dihydroxyvitamin D3 and D2, and these exist, we know it, and we try to give them some clinical relevance. We measure them in research settings, or when we have patients for which the clinical picture does not match the result. And this is something which is frequently done. We measure testosterone, but when testosterone is not really matching with the clinical picture, we will try to look at the testosterone metabolites. So, meteorological traceability. We actually, the ISO 17511 has schemes like this, 5 different schemes. The most simple one will lack, or actually the most simple one will start at the level of the secondary reference measurement procedure. I will try. So it will start here, down. Then you have systems which will start at this line, down, and then we have systems which will start here. And so we will have to define what we want to measure. And sometimes it's very easy. You measure testosterone, it's very easy. Testosterone can be chemically described, it's very clear what the structure of testosterone is, there's no discussion. Testosterone is testosterone. We measure 25-hydroxyvitamin D. It's already a little bit more difficult because we measure the sum of the D3 and the D2, which has implications. We measure TSH. That's a very tricky one because the TSH exists in many different forms because of post-translational transformations. So it gets hooked up with all different kinds of small molecules, and there's not one single chemical structure which defines TSH. So in the first 2 cases, testosterone and 25-hydroxyvitamin D, we will standardize. Because still it's a very simple molecule and we can describe it very well, it's very clear what we want to measure, we standardize. In the case of TSH, which we cannot describe very well, we have a common understanding of what we want to measure, but we have no clear definition, we harmonize. So that is the difference between standardization and harmonization. If what we want to measure can be very easily described, we will standardize. If we need some agreement on what we want to measure, if we have to make a consensus, we will harmonize. So I will guide you through the most important things of this scheme. And actually, just the definition of the meteorological traceability chain, it means that you link the results obtained for a patient sample can be linked to the highest international standards, the definition of the measurement and the SI, via a chain of an unbroken chain of actually calibrators and measurement procedures. So each time this chain should be followed, you can go back to the highest international standards. So key aspects in this traceability chain are actually the definition of the measurement, the translation of this definition into the primary reference material, and making sure that this chain is unbroken, that you can keep the link to the higher level at all times. So for 25-hydroxyvitamin D, we have first defined what we want to measure. And that is actually important in everything we do as analytical scientists. Up front, you define what you want to measure. And then you define what will I be using for, and hence, what are the needs for my method. Based on that, you will derive quality specifications, which means a maximum CV, a maximum bias, and then you start validating and try to meet the criteria you have defined up front. So for vitamin D, we have defined what we want to measure as serum plasma in this system. We actually define the component as total 25-hydroxyvitamin D, which is the sum of D3 and D2, and as I already mentioned, not the 3 epimer. And then we have to define the kind of quantity, which is actually the unit, the amount of substance concentrations, and it's nanomole per liter for 2 things. 1, it's the SI unit, but 2, we measure the sum of D3 and D2. They have a different molecular weight. You can only sum up in nanomole per liter, and never in nanogram per milliliter, because it's just a different molecular weight. You need to work in nanomole per liter. So I will make, or on the slide, the next slide, will have some things I completed. I'm not saying that that will be the definition of the measurement. I think it's up to us to decide. But I have to use something to guide you through the presentation. So I made something up by myself, but I do not hold the truth, so it's open for discussion. So we will try to define the system, the component, and the kind of quantity. And the system, I think, it should be, well, very clear. As PET is bound to the surface of the red blood cells, it should be either whole blood or maybe the erythrocyte fraction of the whole blood. Now, the latter I will not go into discussion on further, because I think nobody in the room does a measurement on the erythrocyte fraction, and I think it's also, I don't feel that that is the way we would like to go, because it complicates things a lot. The component. As we know, PET cannot be described via a single chemical structure. There are over 48 analogues that exist. So we will need to decide what will we measure. Will we measure solely 16O-18-1? Will we sum two or more analogues? If we go for the sum, we should all get rid of the nanogram per milliliter. We can only use micromole per liter, because otherwise you cannot sum up. And also, we need to make sure that we have equimolar measurements, that we can measure all the analogues with exactly the same specifications in terms of CV and accuracy, which is very important, especially if you would like to quantify low abundant analogues. Also, something I think we have to take into account, and it will also be my last slide, what I'm talking or discussing now is an application or a way to use PET in an application. We use it to interpret a PET result in a certain context. It does not limit any research, and it does not limit any laboratory to actually measure also other things. But it should be very clear, if each of our laboratories uses PET to state someone is abstinent or not, it's exactly the same application. We should make sure that if we send a sample around, the answer yes or no is the same in all of the laboratories. That is what I'm talking about now, the application. So that also it's very clear for all of the people who get a result from us and who would like to do some own research, go to the internet, that they do not have to come to us and say, but this number in that laboratory would have meant something else. That is something we really want to avoid. So the kind of quantity, the unit, will have to be the amount of substance concentration expressed in micromole per liter, which is the SI unit. And as already said, if we measure a mixture of analogues, we have no choice. Which will also be very difficult for us because we use nanogram per milliliter ourselves. Okay, the second key element in the meteorological traceability is a primary reference material. We've discussed it yesterday. I think all of us know the issues for PET, but for example, for 25-hydroxyvitamin D, the primary reference material is actually produced by the National Meteorology Institute of the United States, NIST, and it's produced according to the highest meteorological standards. It's the same for many other analytes. Sadly enough, there's only one NMI producing a certain primary reference material. Because the NMIs, they also just actually make agreements. The GRC and Yale will maybe produce a reference material for T4. In Australia, they will produce a reference material for testosterone. NIST has one for 25-hydroxyvitamin D. It costs a lot of money, there's a lot of validation involved, so they actually divide the measurements among themselves to reduce cost and duplication of things. So for 25-hydroxyvitamin D, I have actually just a screenshot of the content. It's D3 calibrator at 2 levels in ethanol, and it also contains D2, and it also contains the 3-epi, which we don't use clinically, but it's contained in the reference measurement material. So, the primary reference material should exactly represent the defined analyte, and in case of a mixture analysis, it should actually allow equimolar measurements. So it should be a well-characterized pure substance, or just as a powder or in solution, and it should have a high purity and a very low uncertainty on the purity, or it should have a very well-defined concentration and a low uncertainty on that concentration. And for PET, of course, I think we all agree that the regioisomeric purity is very important for this analog. Actually, it speaks for itself, because PET 16081 is a different thing than PET 18160. But it should, that's why we say the material should exactly represent the definition of the analyte. Does it need to come from a national metrology institute? I would say in the ideal world, yes, but it's not the case for many analytes. We just need to have to make sure that the materials we obtain try or fulfilling the criteria we need as much as possible. And then something else which I think is very important, or is a key in this meteorological traceability chain, is actually the fact that it is an unbroken chain. That there's no gap at any place, and that you perfectly can trace back from a material at one level to a procedure at the higher level to the procedure, the material above that. And it's an unbroken chain. It's each player's responsibility. On the slides, the general slides, I have a line with all the responsibilities, who's responsible for which level. And this is where good laboratory practices come into play for us as application laboratories. Because it's our responsibility that we do a good job, that we make sure, if we say, I measure PET 16081 in whole blood, that is exactly what I do. So for 25-hydroxyvitamin D, we have well-validated methods which separate the 3 epimer to avoid interference. And actually, we have certified reference materials for 25-hydroxyvitamin D, and I once got a phone call from a laboratory and they said, for this material I'm 5% higher, and for this material I'm 10% higher, and for this material I'm that many percent higher. And then I asked them, do you know what you measure? Do you measure 25-hydroxyvitamin D, or do you measure also the 3-epi? And they had never heard of the 3-epi, and they actually measured the sum of the two, and the differences that they summed up for each material aligned perfectly with the amount of 3-epi D3 in that material. So no wonder that they couldn't meet the bias criteria, they were just measuring the wrong thing. So it's very important that you know what you measure. And then we also need commutable materials. For example, NIST, the first reference material in matrix that they developed, which we use at a lower level, was actually afterwards discovered as not being suited. It was based on horse serum, and it behaved different than a native patient sample in many methods, even in mass spectrometry methods. So they had to actually throw it in the waste bin and start over with serum from human samples, or from humans. So it's very important, this commutability, and I will explain it a little bit further in the slides, because sometimes I will use the term a couple of times more, but somewhere I will explain what it really means. So this unbroken chain is where every player should be well aware of the pitfalls. For PET, it means that the primary calibrator should be regio-isomeric pure. Labs should be aware of post-sampling formation and degradation of PET and should take suited measures to avoid it. We should be aware of hematocrit-related issues when using dried blood spots, not only when we use a classical DBS, but also when we use volumetric dried blood samples. We should validate our calibration procedure. I think we've heard and read between the lines that we all struggle with preparing calibrators. What is the best protocol? When do you spike? How much time do you need it? Or do you allow it to equilibrate? When do you apply it to a DBS card? And so on. And again, the secondary matrix-based reference materials and external quality control materials, they should behave exactly as a patient sample. So they should be commutable. That is also something which is very important, because if they behave differently, we can maybe match the QCs, but we won't get it right for the patient sample. So then there's another level in such a traceability chain, which is the secondary reference measurement procedures, and they allow to bridge between the calibrator and the routine methods. And the difference between just a routine LCMS procedure and a secondary reference measurement procedure is, as I already told you in the beginning when I introduced myself, it's a high demand for precision and accuracy, but it's also the fact that they are calibrated directly with the primary calibrator. I target samples for vitamin D in serum, but I use vitamin D in methanol or in ethanol as a standard, as a calibrator. I never use a calibrator in matrix in the reference measurement procedures. So, and then, of course, we use these reference measurement procedures to target real samples, and it goes like this. It's an EQA organizer, or it's a Siemens, Roche, whatever, who send us samples, we target them, they take the results back home, and they use it to set the basis for calibration of their method or to check accuracy of their methods. So, just an example for vitamin D, it's a little bit small maybe, but this GCTLM has actually acknowledged 3 reference measurement procedures, one at the University of Ghent, one at the CDC, and one at NIST. And then an example of how we applied it. So Waters has a commercially available kit for LCMS users who want to measure 25-hydroxyvitamin D. And if you would look up their statements on traceability, you will find that they have an assignment of the values of their calibrators by using reference measurement procedures, and then the identification of our methods and the name of my former boss. So that's how we use these secondary reference measurement procedures. So for PET, they are non-existing so far. And as I said, often our routine PET analysis make use of matrix-based calibrators. We struggle with targeting or with maybe getting it right. If we would have a reference measurement procedure, it could be of help in just actually verifying the trueness of our calibrators that we use. The same for the quality control samples. Such a reference measurement procedure could actually be used to identify commutability issues. So, as said, the need is in the targeting and validation of what we do at the lower level. So this is actually what I think that the meteorological traceability chain for PET could look like. And we have written a review, Mark and I and a couple of others, in Wired's Forensic Science, which already includes this figure, in which we propose and which we actually level by level also explain all the things that I'm discussing now. So you can actually go to this publication and read it if you would like to remind yourself what I have been discussing. Now, commutability and PET. The definition for commutability is that it's a property of a reference material that relates to the closeness of agreement between results of this reference material and the result of a clinical analyte sample when measured by more than 2 procedures. And with reference material here, I mean calibration standards in matrix, QC materials, EQA materials. And in simple words, usually these are artificially prepared because we need lots of them. An artificially prepared calibrator or quality control material should behave exactly the same as any random patient sample. And if you would look up literature to verify or to check how do we establish whether a material is commutable or not, what we'll do is we'll do a method comparison with 2 or 3 or 5 or 6 or whatever number of laboratories. We measure 40, 50, 60 true patient samples, so native samples, and then we add up the calibrators or the QC materials we want to study, and then we will check whether, if we have a regression line, whether these materials actually are within the variation of the patient samples, or whether they are outside, or even if they are within, whether they are not all at the border, the upper border or the lower border. Maybe I should have added a picture of that, but I didn't. What is understood as artificially prepared, it's actually each manipulation of a sample which may alter its properties. And it goes from pooling of a sample over spiking, freezing, lyophilizing, depleting. And I think we all know spiking, for example, for PET is very difficult. We know that it's if you spike a sample and you would apply it directly, you come into trouble. So spiking is understood as already an artificially prepared sample with a risk of behaving different. Freezing will lyse the red blood cells, and it may impact, for example, extractability. If you have, it might be possible that a lysed blood sample which you apply afterwards to a DBS or another dried sample, that for this lysed sample, the extractability will be different than for the native, non-lysed blood sample. So the same with lyophilizing and depleting samples, it will alter the protein binding, it will alter the proteins, it will alter the binding capacities, it will do so many things to a sample which involve a risk of what you want to do afterwards. And in my 20 years in this field, we have all tried to use spiked samples or pooled samples as a way of making high volume calibrators and QC materials. And often we have to go back and we have to say it didn't work. We've tried it, for example, for free thyroxine. It just doesn't work to spike a sample. Not. So we know that we keep our hands off of it. So it's very important, and sometimes we really have to go the hard route and collect native samples and use these, for example, for QC purposes. So if we compare different methods, we should include single donor unadulterated samples. The samples which are the samples that we use in our, or what we will be using the method for. These are the samples you need to use when you compare methods. And if you compare methods who have maybe a different measurement principle in terms of sample prep, you should make sure that the sample that you use is actually delivered in a form that it's useful for the both methods. So with the use of these non-pooled single donors, native samples is very important to get a very well understanding of how comparable methods are. And again, it's something that in the field of clinical chemistry, we have every now and then we have to readmit and reprogram ourselves and tell ourselves, just do it. It costs you money, it costs you time, but you need to. You cannot just rely on two artificially prepared QC samples to make a comparison. It doesn't work. So again, as a final note, I think it's very important that we all understand very well that applying this reference measurement system would lead to comparable results upon, I mean it here, a clinical use of PET measurements, but I mean upon a use of PET measurements as we do it now. We compare it to a limit, we compare it to a previous value. For this type of use, we should make sure that we all at least use a method which we know is traceable to PET as we have defined it. All the rest, research, should not be hampered by this. You can do research, and I think we need a lot of research to find out if maybe in a couple of years we have to, or we can even improve what we do by adding a measurement or by defining or refining cutoffs and so on. So we did the research and we are actually encouraged to do more research, but for the applications we really need to make sure that we are in line. Otherwise, after a few years we will be confronted with people taking the phone, calling and telling us, yeah, but in that laboratory my PET is of the same order of magnitude, but they say I'm abstinent and you say I'm not. And that is something which we really would like to avoid. And that's why the title of my presentation, because we discussed it, increasing the confidence. I am confident in what I do, but I would like to increase the confidence of the users in what we do. And I think that is very important. So, yeah, just the example in for vitamin D, as I said, the green one we use for clinical purposes, the red one we should never use, and the orange ones we use for research. So with this, I hope I was a little bit, or I was able to explain you a little bit the concept of traceability.
Do we have questions from the audience? As far as I know, the only reference material with blood currently is the one from ACQ Science. Is that correct? Worldwide correct? Or is that just a European feeling?
I actually, well, I'm not. We use the term reference material. It's a material which we can use as a QC material, which can be a secondary matrix-based reference material. We don't use it ourselves. For QC purpose, we actually just use the materials from the EQA scheme, but it's true that there are limited sources of matrix-based reference materials, but I have no clear overview of what exists and what doesn't exist.
Maybe Julia, do you know it? And actually the question is also which, maybe somebody knows which material they use, Avanti polar lipids or severely, but they describe
They tested that, so they prepared different quality control right now with Avanti-Polar, Enzo, and Cerillion, and they sent it to different laboratories for investigation. So I guess they will publish or present the relevant cases soon. From what I know or understood, there is no difference between Avanti-Polar, Enzo, and Cerillion. The preparation of the reference material. That's the only thing I know regarding that. But I have a question because we know that Sweden switched from CDT to PET 10 years ago in clinic, right? Mm-hmm. And from what I know, they run approximately 100,000 samples per year. And of course, Karolinska, Lund, they are fully accredited. The question, how do they do? How did they manage the quality control of their method?
Well, I suppose if you have ISO accreditation for a method,
if you have ISO accreditation for a method, you are required, according to the ISO, for example, ISO 17025 will require you to document validity of results by, and then you have a list of things you can do, and one of these things is interlaboratory comparisons. So if at a local scale they will maybe do a method comparison with all of the Swedish laboratories and they can show that they are in full agreement with each other, that might be sufficient for the Swedish accreditation body to actually, and it's, as a reference laboratory, our activities are also accredited according to 17025. Yeah, so at this high level, we have the same standard to be accredited to, but we have no peers, we have sometimes no reference material, so sometimes you have to work with the things that are available. And we can only try to improve the system and to work together and to get more reliable results by working together, keeping in mind the concepts that have been laid down by others.